My name is Anthony Manecci, FNP student at Winston-Salem State University. This is my friend Jamie Flincham. Going to be doing a head-to-toe assessment. Jamie, you okay if we film this?
Yes.
Very good, sir. All right, so I'm going to conduct some hand hygiene here. I've introduced myself to you. Excellent. All right, sir. So today we're going to be doing a head-to-toe assessment, starting at your head, going down to your feet. Fairly simple. We're going to hit all the major body systems. Excuse me. So I'm observing you here as you sit. I see no obvious signs of distress. You seem relatively comfortable. So I'm going to begin the head-to-toe assessment at the head, beginning with the skin. So generally inspecting your skin, looking for any cyanosis, edema, erythema, hyperpigmentation, hypopigmentation, jaundice, etc. Also noticing his hair distribution on his body. We'll get to your lower extremities in a moment. Noticing hair distribution up top. Everything seems appropriate. I am going to palpate your hair, noting texture, and as I said, distribution is fairly well covered. As you know, bald patches, no alopecia. I'm going to be separating your hair in at least two places. Looking at your scalp, I see no lesions, no open sores, anything of that ilk. Also, I'm going to be looking at your skin, noting, I noted color, noting temperature, so I'm going to feel bilaterally. Very good, and I would feel lower extremities bilaterally as well. Thank you, sir. Nice and warm. Skin feels soft, not dry, not flaking, not scaling, anything of that nature. No signs of edema, no lesions. Checking skin turgor. I'm going to pinch your skin up a little bit on your forearm. Non-tenting. Very good. I also need to inspect your nails. If I can see those, thank you, sir. So we are checking capillary refill on that side and on that side. Nice and brisk, less than 3 seconds. Coloration of the nails appears adequate. They are attached, they're not coming off. Also, if I could have you do the Shamroth maneuver, that is placing your fingers together like that. Take a look at the angle. Angle appears to be approximately 160 degrees, no clubbing noted. So that's general skin and nails. Now I'm going to be going back up to your head. We already palpated your hair, noted texture, nice and soft, not dry, not flaky, no alopecia noted, nothing that would indicate malnutrition. Distribution is appropriate. Now I'm going to palpate the rest of your skull and your scalp and then move down to your face. Okay, so we are palpating. Any tenderness with that?
No.
Okay. And do a little hand hygiene. This will be touching your face. Don't want you to break out. Alright. Awesome. Alright, and again, going to palpate your face here. And again, just let me know if you have any tenderness. Anything?
Nope.
Okay. Going to be palpating your sinuses, frontal and maxillary. Any tenderness with that?
No.
Okay, and no swelling felt, no edema. Now, so palpated your face, palpated your sinuses. Now I'm going to palpate your temporomandibular joint. So if you would, sir, open your mouth, okay, and close, okay, and side to side. Very good. No clicking or popping. Any tenderness with that motion?
No.
Excellent. Now I'm assessing your general neck, looking for symmetry, any swelling, and I don't see any. Trachea appears nice and midline. Now I'm going to go ahead and palpate that to verify the amount of space on either side. Make sure it is midline. Okay, very good. Trachea is nice and midline. I'm going to go ahead and palpate that thyroid gland that's nice and low here, and go ahead and swallow for me. Okay. Does not appear enlarged. I'm going to go ahead, even though it is not enlarged, I'm going to go ahead and listen to bruise with the bell of my stethoscope. Bell. Okay, awesome. Thank you, sir. So that is the head and neck portion of our exam. Now moving into the eyes, inspecting your eyelids and lashes, noticing the hair distribution. The upper eyelashes curve upward, lower lashes curve downward. Eyelids appear aligned, no redness, no swelling, no exudate noted. Also looking at the conjunctiva, I'm going to pull your eye down and up a little bit here. Just look at that underlying tissue. And up. All right. Lacrimal gland does not appear inflamed, no excessive discharge, no redness of the conjunctiva, no discharge there. Excuse me, no redness, no swelling, nothing of that sort. Also noticing your sclera, the color of those. If you would open just a little bit wide for me. Sclera appear nice and white, no hypervascularization, no broken blood vessels, no jaundice, no cyanosis, nice and white. Now, gonna be doing a little hand hygiene since I was touching you. Do the cover-uncover test. So I'm going to hold this paper in front of one eye, note what the uncovered eye does, then uncover the covered eye, and see what it does.
All right.
Here's mine. All right. Okay. And all right. Negative for latent nystagmus. Now we are going to be doing. Got my stuff over here. The wrong head on that otoscope. We are going to be checking the red reflex. Okay. So get these lights out real quick. Ooh, scary. Alright. And if you would, just look forward for me. If you've ever had a picture taken, you've seen those red eyes. That is essentially what this red reflex is. So I'm at a 15-degree angle, approximately 15 inches away from the eye. And I'm just flashing it in there real quick. Okay, good. And other eye. Okay, excellent. Now, red reflex is done. Now we are going to do the, now I need to look for opacities of the eye. And that's actually easier with the lights on. Okay, so checking for opacities that might indicate cataracts. So we're going to be shining the light starting from the side, coming around, just looking at that surface of the eye, making sure it's nice and clear. Okay, excellent. And this side. Excellent. Okay, now beginning the otoscopic exam with my otoscope. So I am going to check your right eye with my right hand and my right eye. Just going to lift your eyelid up a little bit to ensure that I don't get too close. Excellent. And this left one with my left eye and left hand. Again, lifting your eyelid just a little bit. Okay, very good, sir. So I was able to visualize your optic disc on both sides. That is a nice milky pink color. The edges of your optic disc were well visualized, which is non-indicative of papilledema, negative for papilledema. The optic disc was approximately 2 times as large as the physiologic cup, which is appropriate. I didn't see any lesions, any exudate, any hemorrhaging. I was able to also see your retina. The veins are larger and darker than the arteries, which are lighter, brighter, redder. I also didn't see any hemorrhaging, any masses, lesions, or exudate in that regard. Now, so that is the E in ENT. Now moving to the N in ENT, that is the nose. So I am looking at the external structures of the nose, going to palpate the cartilage, make sure there's no masses, any structural integrity issues, masses, lesions, cuts, scars, etc. Now I'm going to visualize the inside of your nose. If you would just tilt your head back a little bit for me. Thank you. Excellent. Okay, so we did eyes, and then we skipped to the N of ENT. So we will keep going with the nose, but we'll jump back to ears.
Okay.
With a different speculum. So the external structures of the nose were intact. Internally, we had I was able to visualize the septum. It was intact, no signs of degradation or puncture. I was also able to visualize the inferior turbinate. Your mucosa is nice and pink, no signs of discharge, no lesions, masses, no signs of bleeding, nothing suspicious. Okay. As long as we're doing nose, go ahead and occlude one side and give a sniff, and other side. Okay, nose is nice and patent. Now we're going to jump back to the ears. So, looking at the external structures here, pulling on that. Any pain with that?
No.
Okay, so negative for otitis externa. Noticing the condition of the ear, no lesions, masses, no signs of cuts or trauma. Going to visualize the internal structures with the ophthalmoscope here. Pulling the pinna up and back. Visualizing the ear canal and tympanic membrane. Okay. The canal has a little cerumen in it, but is otherwise free of foreign bodies. No erythema, no swelling, no signs of trauma. The tympanic membrane is a nice pearly gray, cone of light approximately 4 o'clock. Pearly gray, flat, no signs of puncture. It is intact. Because it is flat, there's no signs of edema, not suspicious for impaired mobility. Slow this down. Now, so we've looked at the external, internal, the canal, the tympanic membrane. Now we will be moving to the special tests, the Weber and the Rhine, utilizing this tuning fork. The Weber tester, I'm going to strike the tuning fork, place it on the top of your head, and please let me know if you hear it better in one ear versus the other, or approximately equal in both.
Okay. It's fairly equal.
Fairly equal? Okay, excellent. Now we're going to be doing the Rhine test, which is similar. I strike the hammer, I place it on your mastoid bone.
Okay.
You tell me when you stop hearing it.
Okay.
At that point, I will then switch it to in front of the ear. You should hear it again, and then you tell me when it stops again for you.
Okay.
Okay.
Okay. Okay.
Okay. And we would do that bilaterally. Okay. And the air conduction versus bone conduction, the length of time that you hear that should be approximately 2 to 1, and yours was approximately 2 to 1. Excellent. Okay. So we have done the ears, we've done the nose prematurely. Now we're going to be moving to the throat. So I'm going to be visualizing the external structures of the mouth, looking at your lips. They are nice and pink, non-cracked, no signs of cyanosis, masses, lesions, open sores, anything of that nature. Go ahead and open your mouth for me, sir. And if you would say ah.
Ah.
Okay.
Ah.
Very good. And give me a nice toothy smile. Okay. Very good. Excuse me. So, internal structures. The uvula retracted when the patient says ah. Soft palate, uvula. I was able to visualize your tonsils, not very well, but a little bit. I didn't see any swelling or signs of infection there. Your buccal mucosa is nice and pink and moist. That's the internal lining of your cheeks.
Okay.
Tongue is nice and pink. You were able to move that fairly easily, it appeared. Teeth appear nice and in line. No missing teeth, no crooked teeth, no sign of decay or disease. Gums are also nice and pink. I didn't notice any bleeding or retraction of the gum line. Tonsil, soft palate, uvula, lips, buccal, tongue. I think that's all of them. Now we will be moving to the lymph nodes. So I'm going to be doing some palpation. Okay, so I'm going to first palpate your occipital lymph node, which is just on the back here. See if I can. Your post-auricular, if you would turn your head for me, sir. Thank you. Post-auricular lymph node behind the ear here. Pre-auricular just in front, and I am palpating bilaterally. Tonsillar is just at the bow of the jaw here. Tonsillar. Submandibular and submental. Alright, now with your head still turned like that, visualizing the sternocleidomastoid muscle. Anterior to that is the anterior cervical chain, palpating that. Okay, and behind that, before the trapezius, is the posterior cervical chain, palpating that. And no enlargement noted. Also palpating the supraclavicular, finding your sternal notch and your clavicle. Got a high clavicle. Okay, palpating that. No palpable nodes there. If I could borrow your arm, I'm just going to bend it up, and you can relax your head however you want to. Flexing the arm a little bit, finding the epitrochlear nodes between the bicep and the tricep, coming up the arm, and none noted there. The axillary nodes high in the armpit, and I don't feel any there. And so that was epitrochlear, that was axillary, and I'll spare Jamie the indignity here, but the inguinal nodes would be kind of along the bikini line, if you want to term it that way, sort of where the femoral pulse would be, and I would feel that bilaterally. Now, a little hand care. So those are all your lymph nodes. Now we will be moving to, yeah, that concludes your head and neck. Now we're moving to chest.
Okay.
So now we are going to be doing cardiovascular. It would be easier if you had no shirt on, but Jamie and I made a deal that he wouldn't have to take his shirt off for this, so we're just going to verbalize those parts of the exam. So I would be inspecting, obviously, your upper chest there for heaves or pulsations, and sometimes I do have patients where you can't see their pulses through their skin. Also looking at your peripheries, so looking for any, assessing your venous pattern for prominent vasculature. That was on our checkoff. Don't see any prominent vasculature here or anything suspicious. If you would raise your pant leg for me, sir. Okay, excellent. And I would check that bilaterally. If you were wearing a patient gown or shorts, I would have you stand up. I'd be able to see any varicosities. They would pop out as soon as you stood up, but I probably won't be able to see those with jeans on. I also need to inspect for jugular vein distension. If you would, sir, just kind of relax back. I need to get approximately 45-degree angle. We are filming in my house, and I don't have an examination table, so we are utilizing the recliner as the closest approximation of said examination table. Now you are about a 45-degree angle. Ideally, I would use tangential lighting to really make this more visible to me. If you could, sir, turn your head to the left, about a 45-degree angle. Excellent. And now I am just watching that jugular vein. And while I can see your pulse, I don't see any distension, which is fine and dandy. Alright. And now I am gonna palpate for any thrills. So I'm gonna palpate your carotids here. Most people palpate in the upper third. We are actually taught to palpate in the lower third. So I'm just gonna go just off of your windpipe there. Okay, I don't feel any thrills. Feel your pulse, don't feel any thrills. Excellent. I'm going to be palpating the rest of your pulses here. As I do so, I'll also look for any thrills. In the meantime, I'm going to palpate your PMI, your point of maximal impulse. That is located in the mitral area. It is also the location of what we would term the apical pulse. That is at the left side, fifth intercostal muscle, midclavicular line. So I'm going to find your sternal notch. Okay. Come down to your angle of Louis, or your costal angle. Sternal angle there. Coming over midclavicular line. That is your second intercostal. Coming down third, fourth, and fifth. And trying to palpate this PMI. And I do feel it a little bit. Very good. So that is all of inspection. We have begun palpation. Palpated the thrills, palpated PMI. Oh, now we are going to palpate the rest of your pulses. Okay, so I will be checking bilaterally to make sure they are nice and equal. Thank you, sir. Radial pulse, nice and equal. Brachial, yeah, very good. Alright, nice and equal bilaterally. We've already palpated your carotids. Going to be palpating your popliteal, which is just behind your knee. Now ideally I would check them at the same time, however you've got rather large calves, so I probably need both hands to get around that. Okay, nice and strong. Also we have the posterior tibialis, which is medial malleolus. I wish we had a cameraman. Be checking this bilaterally at the same time, ideally. Nice and strong. And then you can relax just a little bit. The dorsal pedalis is just medial to the tendon that leads to the great toe. Okay, and I would also check that bilaterally. Okay. So now I'm going to be auscultating with the bell of my stethoscope, not the diaphragm, the bell, your carotids to see if I can hear a bruit. Okay, not that one. There we go. All right, sir, if you would just kind of hold your breath for just a moment. All right, very good. You can breathe. And hold again. Very good, sir. So I was able to hear your pulse. I did not hear any bruits, which is very good. Now I'm also going to be listening, again with the bell of the stethoscope, to the pulses that I can hear in your abdomen. Okay, so if you would kind of lay back and relax. I know it might be hard to see on here. Ideally I would have him flat. I'm kind of going to have him more upright just so you can visualize what landmarks I'm hitting. The abdominal aorta, I would listen to at a point approximately halfway between the umbilicus and his xiphoid process, slightly inferior to that midway point, but still midline. Iliac will be 1 to 2 inches off center on either side, coming down. Renal will still be on that same line, approximately 2 inches off center, but at the level of the umbilicus. And then femoral would be lower to that. Again, I will spare Jamie that embarrassment and just kind of demonstrate on myself where that would be located. Listening with the bell of the stethoscope. Okay, approximately halfway, slightly inferior. Okay, that's abdominal aorta. Now iliac. Other side. Renal, same line at the level of the umbilicus. Okay. And again, I won't check the femoral on Jamie, but it would be approximately at the, what you might term the bikini line, down here. Now I'm going to be, we have palpated oid pulses, we have listened to the carotid and the sounds you might hear in your abdomen. Now we're going to be listening to the sounds you would hear at your chest. So I'm going to go through them once with the bell of the stethoscope, and then once more with the diaphragm of the stethoscope. Okay. So we're going to find your sternal notch, the angle of Louis, that second intervertebral space coming over to the right, second intercostal, not intervertebral, intercostal at the sternal border. So right second intercostal would be aortic. Gonna go ahead and listen there. R2, sternal border. Okay. Second intercostal space, left side, sternal border is pulmonic. Third intercostal space, left side, sternal border is Erb's point, also called the second pulmonic site. And fifth intercostal space, left side, sternal border is the tricuspid valve. And fifth intercostal space, midclavicular line on the left side is the point of maximal impulse. It is the point of mitral valve closure, and it is what we would call the apical pulse. Okay, and then going to listen to those same sites again with the diaphragm. I'm just going to roll through them since we already discussed where they are. Excellent. Thank you, sir. So now we have concluded the cardiovascular portion of the exam. We are now moving into respiratory.
Okay.
So I'm noticing you don't appear to be in any respiratory distress at the moment. I'm noticing the ease of your respirations. I'm taking count of your respirations. I would say they're at about 16 respirations a minute. Also, unlabored breathing, even, and an appropriate depth of respiration. Also, noticing the physiologic structure of your chest, your thorax there. I don't see any abnormalities. You don't appear to be using your accessory muscles, and chest rise and fall appears symmetrical. I'm going to then generally palpate. Let's turn you a little bit here. 45 now. Going to be, we've inspected, now looking for stability of your chest, going to be palpating generally to let me know if you have any tenderness. All right. Any tenderness with that?
No.
Okay, and you felt nice and stable.
Yes.
I also didn't note any crepitus, which is another thing I would be palpating for. Now I'm going to palpate to determine symmetrical respiratory expansion. So if it could have you stand up, sir. Yeah, thank you. Okay, so I'm going to find his 10th rib on the side here. Okay, that feels like approximately the 10th rib. I'm going to form kind of a V pattern with my hands. Pinch some skin in the middle. Okay, and if you would, sir, take a nice deep breath. Very good, sir. And the expansion of his lungs, as indicated by the expansion of my hands, is nice and even and symmetrical. All right, so you can have a seat. All right. So we have palpated, generally, we have palpated for expansion. Now we are going to be palpating for tactile fremitus. Okay, so I'm going to have you repeat the words 99 over and over. I'm going to place the ulnar surface of my hands posteriorly initially and then anteriorly. I should be able to feel the vibration from you saying 99. However, if I were not to be able to feel that, that would be indicative of a mass or possible consolidation. So I'm going to have you stand up again.
All right. Let's go aside.
Okay. So finding the scapular line, staying inside of that, working from the apex down. All right, sir?
99, 99, 99, 99, 99, 99, 99,
Okay, and moving laterally.
99, 99.
Okay, very good. And if you would turn. Thank you, sir. Mid-clavicular line, same thing, starting at the top, going down.
99, 99, 99, 99, 99, 99.
Very good, sir. All right, and you can have a seat. Do a little hand hygiene. All right, so now we are going to be percussing. Excuse me. I'm just going to percuss in a ladder pattern. You can stay seated for this. It's actually a little easier for me. But we're going to be percussing anteriorly, posteriorly, and laterally down the mid-clavicular line. The lungs are filled with air, so they should be nice and resonant. Dullness might be indicative of consolidation or potentially a mass. So starting at the first intercostal space, mid-clavicular line, hyperextending the left DIP and striking with the right middle finger. And I should be doing it in the ladder pattern, so. Skipping any breast tissue. Alright, so, and if I could,
They'll just stand up.
okay, easier.
Be easy for you.
Alright, scapular line, staying inside of the scapula, but starting at the top, going down. Ladder pattern. And going a bit lateral. Alright, very good, sir. Stay standing for me. We are now going to percuss for diaphragmatic excursion. So what I'm going to have you do, sir, is take a nice deep breath in. I'm going to percuss for dullness. That will indicate the level of the diaphragm. I would mark it with a piece of tape. However, I used all my tape on a previous video that didn't turn out. So I'm just going to verbalize that. That mark would indicate the lowest his diaphragm would be expected to excurt to travel to. Then I will have you take a deep breath out. Diaphragm should retract. I will percuss for that level, and that will give me the distance of diaphragmatic excursion. Alright, sir, if you would take a nice deep breath in for me. Okay, approximately there. I would find that same level on the other side. It would be normally for me. Okay, and again, ideally, I would be marking these areas with tape. Now, take a nice deep breath out for me, sir. Okay, and I would mark that area and measure the distance in between. Thank you, sir. All hand hygiene. Okay, so that was the two types of percussion for respiratory. Now we're going to be auscultating. Again, in a ladder pattern, anteriorly, posteriorly, and laterally, with the diaphragm of the stethoscope. Just breathe normally for me. Very good, hand in the back, relax. Avoiding the scapula, but starting nice and high. Ladder pattern, and lateral. Alright, thank you, sir. Alright, that concludes the respiratory portion of our examination. Now moving into the abdominal portion. So, again, I made a deal with Jamie. Shirt can stay on, so we will just verbalize some of this. However, if you were exposed, I would be able to visualize your skin, looking at the contour of your stomach, if it was flat, distended, or perhaps just rounded. Also, looking for pulsation. Have some patients where you can actually see their pulses through their skin. If I could have you, sir, go ahead and lay back in the chair and kind of do a crunch for me. I just want to make sure your muscles engage. Okay. Now, ideally, we would just be visualizing that, but I find it easier to determine based on palpation. Now, so we have inspected everything. Now we will be auscultating. This is different from other body systems in that you auscultate before you palpate or percuss because you do not want to alter bowel sounds. So I'm going to listen with the diaphragm to all four quadrants. Okay. Nice and active. Nice, normal, and excuse me. Nice and active, not hypo or hyper. I would listen for up to 5 minutes if I didn't hear any before I determined that they were absent. Excuse me. Now I'm going to be percussing generally the four quadrants. So again, just hyperextending. You could either do the four quadrants or the 9 areas In this instance, I will choose to do the 4 quadrants. So we have percussed generally. Now I'm going to be percussing for the liver width. Trying to find the lowest rib. That's where I would expect the liver to be. Starting at the umbilicus, percussing upward to find the lower border, and then starting from the nipple line and going downward to find the upper border. And that width should be approximately 6 to 12 centimeters. So, and again, ideally the patient would be seated or laying flat, but we're working with a recliner. Okay, I would mark that with a piece of tape, but again, utilized that on a previous video. Starting at the nipple line, working down, the right side midclavicular line. Okay, and I have doneless there. Mark the 2 sites and measure the distance between 6 to 12. Now I'm going to be percussing for splenomegaly. If the spleen were enlarged, we would expect a larger area of dullness.
Okay.
That is on your left side. So if I could have you just kind of lay flatter and perhaps turn on to your right side a bit. There we go. When doing the abdominal examination, the practitioner is always supposed to stay on the right side, so I'm going to be reaching over, finding his mid-axillary line, and percussing along that. I'm kind of covering you up, aren't I? Let's do that. Okay, very good, sir. Don't see any indication of splenomegaly. Now, last percussion for the abdomen is the CVAT. Looking for CVA tenderness, so if I could have you sit forward. All right. Okay, and with the ulnar surface of my hand, I'm just going to lightly strike your CVA. So just kind of lean forward for me. The costovertebral angle back here. And any tenderness with that?
No.
Okay, very good, sir. So we will now move to palpation. So again, you can kind of lay back. Okay. Again, ideally, the patient would be flat, but we're working with a recliner. So first, I'm going to be doing some light palpation, generally in the 4 quadrants. And just tell me if there's any tenderness. And I'm just looking for any masses, any firmness where there shouldn't be any abnormalities. Now I'm going to be doing some deep palpation. It should be approximately 2 to 3 inches in depth. I'm going to go a little easy on Jamie here because he's a friend, but I would be palpating pretty deep. And again, those 4 quadrants. Okay. Now I'm going to be palpating for the liver border. I'm going to support your lumbar with, excuse me, with my left hand, and you can remain flat. Palpating with my right hand in a downward and superior motion to try to find that liver border. Okay, right side, midclavicular line, find that last rib down a little bit, and if you would take a deep breath for me, sir. Okay, and I actually feel that. Now, you can breathe normally. And similarly, I'm going to be trying to palpate your right kidney. It's going to be just slightly lower. Again, I'm going to support your lumbar and palpate with my right hand. Okay, and I was able to palpate that as well. Now I'm going to be palpating your left kidney. And again, anytime you're doing a abdominal examination, the practitioner is supposed to be on the right, so I'm going to be kind of reaching over here. Again, supporting your lumbar and palpating with my right arm. Very good. Okay. Harder to feel that one, but I did feel your right one. Now, they don't have us palpating for the spleen, but I'm going to be palpating for your abdominal aorta. That should be similarly to where we auscultated. It should be approximately midline, slightly inferior between the xiphoid and the umbilicus. I'm going to try to capture that between my fingers here. Relax. So now I'm going to check your, tell me, cutaneous reflexes, cutaneous abdominal reflexes. So I'm going to get this big Q-tip here. And again, promised Jamie shirt could stay on, so we're just going to kind of do this over. But I should still be able to see if you have any sort of a reaction. What we would be looking for is the musculature tightening towards the umbilicus with stimulation, going at somewhat of a 45-degree angle here around the umbilicus. I probably shouldn't be holding the umbilicus. Okay, so maybe a slight reaction to that, but that is your abdominal cutaneous reflex. Now, for a special test, checking for appendicitis, we have a couple options, but the one we're going to do is checking for rebound tenderness. So in the 4 quadrants, I'm going to push down slowly and then release quickly.
Okay.
If you were positive for rebound tenderness, you would have a fair amount of pain upon me releasing. Okay? So slow in and off. Excellent. Thank you, sir. And a little hand hygiene. All right. And this concludes the abdominal portion of the exam. Now we're going to be moving into the musculoskeletal. So we're going to be doing the upper extremities. So first I'm going to be just inspecting generally your bones, your muscles, bony prominences, ligaments, and tendons. Don't see any asymmetry, any swelling, any deformities, any excessive swelling, anything of that nature. Bilaterally. Now I'm going to be palpating, starting from the top, working my way down. So I'm going to find your sternal notch, come across the clavicle here, find the AC joint, find the coracoid process, yep, and then on the superior portion of the humerus, find the greater tubercle, finding that groove there, the tubercular groove, where one would find the brachial tendon, bicep tendon, excuse me, that runs through that. Then I'm going to have you kind of bring your arm back for me. Okay, excellent. And I'm going to palpate for the subdeltoid and the subacromial bursa. I don't feel any inflammation there. You can relax for me, sir. I'm going to spin you a little bit. So I'm looking for the spine of his scapula that runs horizontally, excuse me, approximately here. The musculature above it would be the supraspinatus, the musculature under, the infraspinatus, and the teres minor is more lateral and kind of runs at a 45 over here. Palpating those. Any tenderness with that, sir?
Yeah.
Okay, very good. We'll come back around. So that is everything for the shoulder. We are now moving to the elbow, if I could flex. So we have the medial epicondyle on the inside, the lateral epicondyle on the outside, the operculum process, the pointy part of the elbow, essentially, and the ulnar nerve running between the operculum and the medial epicondyle there. All right, and then moving to the wrist, that's wrist for those of you who hit puberty, we have the ulnus, the ulna, and the radius, the radial styloid bone. We have the, I suppose maybe this way would be better, the carpal bones, the metacarpal bones, the metacarpal phalangeal joint, palpate the joints and the grooves in between. We have the anatomic snuff box, the kind of musculature between the thumb and the first finger there. Then we have the PIP and the DIP as the distant intermediate phalangeal joint there. DIP and PIP. So now we're going to be moving into range of motion since we've palpated everything. So I'm going to have you just kind of mimic what I do, if you don't mind. Okay. So with your shoulder, and I would be palpating bilaterally, but for time we'll just do the one. 45 minutes already. All right. So I'm going to have you flex your arm forward, and extend backward. Excellent. Now I'm going to have you flex, extend, adduct across your body. Yeah, kind of a dab.
Yeah.
Then we're going to abduct. So hand at your side, palm towards you. Yeah. Out to the side. Okay, and then turn upward and bring it up. Okay, excellent. Now we're going to do some external rotation. So kind of like you're throwing a punch almost, more so. And then externally rotate. Okay, and now internal rotation, kind of behind your back, like you're scratching your opposite scapula there. Very good. Okay, so that's range of motion. Now we're going to be testing strength. To test the strength of the shoulder, we're going to go ahead and do empty can test. So place your arms out and pretend like you're emptying a couple of cans there. I'm going to push down, resist. Okay, excellent. And now hands at your side. Elbows nice and tight. And resist, or excuse me, try to push out against my resistance. Very good. That's checking for supraspinatus strength. Now we're going to check the strength of the elbow. So if you would just kind of relax, okay, and try to flex against me. Very good. Now we're going to check strength of your wrist, just kind of straight out. And I'm going to push down, try to resist. Okay, and the other way too. Yeah. Okay, very good. Now squeeze my fingers nice and hard, checking strength of grip. Excellent. Now going to, now we did not do range of motion, on anything else. We did flexion extension, right?
Mm-hmm.
Okay. So we did range of motion on the shoulder, range of motion on the elbow, flexion, extension, and hyperextension. Okay. Radial deviation, ulnar deviation. Make a fist, you have a fist. That is flexion of the dips and pips. Pips and dips. And then extension. Okay, very good. Abduction and adduction. Excellent. Flexion of the thumb to the bottom of the fifth finger there. And extension back to the side. And then abduction, kind of lobster claws here. Okay, and adduction, bringing it back. Okay, excellent. So now we have completed range of motion on the upper extremity. We got to strength all the way down to the hand. Here we're doing grip. If you would, adduct. And resist me closing, we'll do bilaterally. Okay, excellent. And now kind of bring your thumb to your pinky there and resist me pulling apart. Okay, so now we're going to be doing a special test to check for rotator cuff injury. We'll be doing the drop arm test. So if you would, just bring your arm out to the side, okay, and slowly bring it down. And if you had a rotator cuff injury, you would feel pain between 90 and 120 degrees there. Any pain?
No.
Okay, fantastic. Now, one special test also for carpal tunnel. So I'm going to have you just kind of bring your arm out just nice and straight, and I'm just going to tap this medial nerve. Any tenderness with that? Okay. And that is Tunnel sign. We'll do a little hand hygiene. Now, lower extremities. If you would, sir, kind of recline full. Actually, if you would stand.
Okay.
Thank you. Okay, so again, I would be visualizing the bones, muscles, checking for atrophy, any physical deformity, none noted here. I'm going to be palpating your ACES, which is the frontal portion of your pelvis. So we're just going to find that real quick. Okay. The iliac crest. Take a step forward for me. So ACES, more frontal. Iliac crest kind of forms a belt on the side, if you want to think of it that way. So we're really going to palpate to find that. Okay. So iliac crest kind of forms the saddle, and then if you would turn more for me, sir. The PIP, Jamie's a friend, so I'll just kind of demonstrate it on myself. The PIP would be quite low where the sacrum comes into contact with the spine. The iliosacral joint we would also palpate. Again, that's a bit low, but I would palpate that as well. You can have a seat, sir. I wish I had a drink. So we have palpated the structures of the upper of the hip, also the greater trochanter, if you sort of bring your hips to the side, that is the upper portion of the femur. So now palpating the structures of the knee. We have, if you kind of lean back, I think we can get that in the shot. Trying to speed this along so we make our cutoff time. Okay. All right, sorry. So finding the patella. The patellar tendon is below that. On each side, feeling for the medial and the lateral meniscus. I don't feel that. Also, the medial and the lateral condyle of the femur, the medial and the lateral tibial plateau, and the medial and the lateral collateral ligament on each side. Okay, and that is in that tibular femoral joint there. Also feeling the supra and the pre-patellar bursa for any inflammation of that. If I could get you to raise your feet up for me.
Both of them.
Here, there you go. All right. So just palpating right down here. So yeah, I think you can see that. Let's do this one. Okay, so we have the Achilles tendon running along the back here. We have the posterior and the inferior calcaneus. We have the lateral and the medial malleolus. We have the metatarsophlangeal joints between the toes here. We would palpate the joints as well as the grooves in between. We would check, we're not at range of motion yet, the plantar fascia. We would palpate that as well for any tenderness. So now we're going to be moving into range of motion. So shot back on here. We'll go in reverse order since you're already up. All right, so range of motion for the lower extremities here. So we're going to do toe flexion and extension. Excellent. Now you're going to invert your heel. Yep. And then evert the other way. Just the heel itself, yeah. Now we're going to, I should probably do this part, abduction and adduction of the forefoot. That's not a lot of movement, but we have abduction and adduction. If you would go ahead and dorsiflex and plantar flex your heel, internal and external rotation. Okay, now we'll be moving to the knees, so if you would go ahead and sit up for me, sir. Okay, so knee extension and flexion. Okay, very good. And internal and external rotation.
Let me sit on the edge a little bit. There we go.
Okay, excellent. And then we're going to be doing rotation of your hips. So you can go ahead and stand up for that. So flexion. Very good. And extension behind. That works. Very good, sir. Abduction away from you. And then adduction just a little bit inside of midline. Yep, there you go. Excellent. Now, if you want to have a seat, we will do internal rotation and external rotation of the hip. Go ahead and lay back for me. Okay, now this one's kind of difficult, so I'm going to help you through it. Okay, so with external rotation of the hip, we're going to go ahead and go flaccid here. Okay, so we're going to externally rotate your hip and bring the distal portion of your foot in to really optimize that external rotation. So we have that, and then internal rotation is just the opposite. We're going to bring the upper leg in and the outer leg out. Okay, excellent. And while I have you in this position, we'll go ahead and do the special test for meniscal tear. That is the McMurray test, which is actually very similar. So we're trying to impinge the meniscus on either side. So what we're going to do is externally rotate. I'm going to try to really impinge that, so I'm really bringing this distal portion of the leg in, and I want you to try to extend your leg. Okay? And any clicking would be a positive sign for the McMurray test. And again, we're going to go inward and try to bring this lateral leg out and really try to impinge that lateral meniscus and go ahead and extend. Thank you, sir. Very good. I'm going to do a little hand hygiene since I've been touching feet. All right. Now. Okay, so that was our special test. Now we're also going to do a special test to check for ACL or a PCL tear. So maintain the same position.
Okay.
Just kind of bring this up at about a 45-degree angle there. Now we are gonna just pull on the tibia. Okay, 45-degree angle. Pull forward on the tibia. That's the anterior drawer. If there was bogginess with that or excessive play, that might be a potential warning sign. And then we're going to push on the tibia. That's the posterior drawer sign. Okay. Very good, sir. And you can go ahead and sit up for me. So we ran through palpation, we ran through range of motion. We didn't do strength, but we did do our special tests. So we're going to go ahead and do strength at this point. So if you would, just against resistance, we're going to do hip flexion. So just try to bring your hip up against, yep, okay, excellent. And try to push against. Okay, very good. And extension. Okay, and flexion. Very good. Go ahead and put your feet up for me.
Gotcha.
Okay. Okay, and push against, like a gas pedal, and pull. Okay, and that is plantar flexion and dorsiflexion, nice and strong. Again, little hand hygiene here. If I can get it open. Okay. So that was lower extremity. Now we're going to be doing the spine. So if I could have you stand up and turn back to the camera. We are going to be inspecting the spine for alignment. From C7 to the gluteal cleft appears nice and straight. Go ahead and bend over for a moment, sir. Okay, spine still appears nice and straight. Back up. Thank you. Now I'm going to be palpating the spinous processes right down the middle, the cervical facets, which are just slightly to either side, lateral, and the paravertebral muscles, which are again slightly more distal, and just palpating for general tenderness in that area. So palpating again spinous processes, looking for tenderness and or step off, cervical facets slightly off center, again looking for tenderness, and paravertebral muscle, again looking for tenderness. I would also palpate the sacroiliac joint, which is very low. Jamie's a friend, so just going to verbalize that. Now I'm going to percuss the spine for any tenderness, again using the ulnar surface. Okay, any tenderness?
No.
Okay, excellent. Now, okay, again, bend for me. Okay, so we have flexion of the spine and back up and kind of hyperextend to the rear for me. There we go. That's hyperextension. And if you would bend laterally, excellent, and to the other side. Fantastic. And if you would rotate, but like a washing machine.
Like, oh, okay.
Like,
Oh, okay.
there you go. All right. And then those same things with just your neck. Okay. So we're going to do flexion, hyperextension, rotation, and lateral bend to the side and to the side. Very good. Any pain with any of that? Okay. And you can have a seat, sir. Little hand hygiene. All right. So we have done upper extremity, lower extremity, back, or excuse me, spine. Now we will be moving to neuro. So I have several things for you to smell. We'll be starting with olfactory, central nerve 1, which is olfactory. We've already checked patency. I have 2 smells here for you.
Okay.
Okay, and you just identify them with your eyes closed.
All right.
Okay.
Alcohol.
All right, and this one.
Mint.
Okay, excellent. Central nerve 1 in place, olfactory. Now we're going to be checking your optic nerve, which is central nerve 2. We do that through several things. One, we have a Rosenbaum chart here. I'm going to hold this 14 inches away from you and just read the top line for me. It's that chart you see at the doctor's office.
Okay.
Okay?
AESD.
Great, 20/20. Excellent. Okay. Now, we're also going to be checking PERLA, pupils equal reactive to light, pupils equal, round, reactive to light, and accommodating. So if you would, just look forward for me. I'm going to shine a little light in your eye, looking for direct and consensual constriction. So shining a light in one eye, looking for direct, and while shining a light in that same eye, looking to see if the opposite eye also constricts. So, okay, we have direct, and then shining a light in that same eye, but looking at the opposite eye, I see consensual constriction. And same thing, opposite way. Direct, and looking at his opposite eye, shining a light in the same eye, consensual constriction. Very good. Pupils are equal. They are round. They are reactive to light. Now looking for accommodation, so I'm going to have you look. I'm going to raise one finger that is near, and I'm going to raise one finger that is far. I'm going to have you just focus on one and then the other.
Okay.
Okay? Now kind of open your eyes so I can see your pupils. There you go. All right, and bam. Okay, excellent. So we had constriction with the close object and dilation with the distant object, which is accommodation. So then we have cranial nerve 2. We did that. Moving on to cranial, additionally with cranial nerve 2, we are going to do the confrontational wiggle test. This checks your peripheral vision. So I'm just going to have you just look straight.
Mm-hmm.
I'm going to have my hands around you and bring them more frontal, wiggling them. You let me know when you see them, okay?
Alright. I can see that one.
Uh-huh.
That one.
Okay. And a little.
Yeah.
Okay.
Yes.
Okay. If I was suspicious of a septal defect, I would have you, and we'll go ahead and go through it, cover one eye. Go ahead and cover one. I will cover the same eye, opposite eye, same side as the patient. We're going to come from this way. Tell me when you can see it.
No.
Okay, and
No.
okay, very good. So that is cranial nerve 2. Now we're going to be doing cranial nerve. Cranial nerve 2 is the optic. We're going to do 3, 4, and 6, which is oculomotor, trochlear, and abducens. Ha! So, just going to have you follow my finger, 6 cardinal fields of gaze. Okay. Go up. Excellent. Okay, and this is the fun one. There you go. All right. 3 is most of ocular movement, up, out, and in. 4 is accommodation, looking at the nose, that inward downward rotation, and 6 is just lateral outward rotation. Now we're going to be doing 5 is the trigeminal. That has motor and sensory input. So if you would, go ahead and puff your cheeks for me. Show me your teeth. Raise your eyebrows nice and high, and close your eyes nice and tight. Okay, that is the motor. Now I have sensory here. I have some soft 4x4s that I'm opening. Go ahead and close your eye. I'm going to touch the 3 places that innervate from facial nerve, the facial nerve, cranial nerve 5. You just tell me when you feel something touching you.
Feel it. Feel it. Feel it. Feel it. Feel it. Feel it.
Okay. And that is the ophthalmic, maxillary, and mandibular innervation of cranial nerve 5. Cranial nerve 5 is also responsible for the corneal reflex. I'm not going to do it to you, but we would be approaching from the side, having the patient look the opposite direction and up, and gently touching the eyeball to elicit a response, blink. But that is also cranial nerve 5. We've gone through 6 already. 7 is 7. Cranial nerve 7 is no, cranial nerve 5 is trigeminal. That's why there's 3 sites of innervation. Cranial nerve 7 is facial. For facial, we are gonna have you grit your teeth. Okay, nice and strong, and do it again for me. Okay, and I'm feeling the temporal and the mastoid over there muscles. Nice and strong reaction, that is 7. 8 is ocular. I'm just going to stand behind you, rub my fingers, doing the finger rub test. Tell me when you hear my fingers and on what side.
Right side, left side.
Okay, excellent. That is 8, 9, and 10 go together. That is the hypoglossal and the vagus nerve. We'll test those together. Go ahead and open your mouth for me and say ah.
Ah.
Okay. The uvula retracts. That is hypoglossal. We also have a nice vocal tone. That is 10, vagus nerve. 11 is accessory. If you would, sir, shrug your shoulders for me. Okay. And against resistance, turn your head. Okay. And the other direction. Okay. Excellent. That is 11, which is accessory. And 12 is glossopharyngeal. If you would, stick your tongue out. Wave it side to side. Okay. Put it back in your mouth and push against your cheek with it. Testing strength. Great. And the other one. Excellent. That is cranial nerve 1 through 12. I'm going to do a little hand hygiene over here. Now we are moving towards this. Now I'm going to be checking with the tuning fork vibratory sensation. Okay, I'm going to strike it, place it just this way at the base of your thumb here, and you tell me when you feel it stop. Okay, go ahead and close your eyes.
Stop.
Very good. And I would do that bilaterally. I could also do it on his toe. Great toe there. So now I'm going to check something called stereognosis. I'm going to place something in your hand with your eyes closed, and you tell me what it is. Yeah. Yeah, you can feel it.
Quarter.
Yep. Very good. Okay. Stereognosis intact. Now I'm going to check your gait. If you would stand up for me and just walk. Well, I can see it. If you would just walk in a straight line across. Okay. No impairment of gait. Balance appears intact. If you would walk on your tiptoes for me.
Okay.
And on your heels. And then one time heel to toe. Excuse me. Excellent. Now I'm going to be doing something called the Romberg test.
Okay.
Basically, you're going to stand with your heels together.
Okay.
And I'm going to see, you're going to close your eyes, and I'm just going to observe for sway. I'm here to catch it if you need anything, but stability appears intact. Very good job, sir. Now I'm also going to be checking your deep tendon reflexes. Actually, before I do the deep tendon reflexes, we need to go ahead and have a seat. I'm going to have you, where's my hammer? I'm going to have you do a rapid alternating movement test. So I'm going to have you take your hands and just go back and forth as fast as you can. Okay, excellent. Now we're going to do a point-to-point test. I'm going to have you touch your nose, and then take your finger and touch my finger. I'll be moving my finger around.
Okay.
Excellent. All right, deep tendon reflexes. Going to be doing the brachioradial. Okay, so just kind of relax. I'm actually going to take your arm and kind of go across like that. Okay, and it's higher than I think it should be. Okay, and I see a little flexion of the arm, the thumb. I'll get it, the thumb. Now I'm going to check the brachial tendon, same sort of thing. Okay, and extend. Oh, it helps if I hit my thumb instead of you. Okay. Okay, very good. I would be doing that bilaterally, checking the patellar reflex, hitting that patellar tendon. Okay, very good, little response there. Checking the Achilles tendon. Just striking the Achilles from behind. Okay, excellent. And that's all of them I have to check. And then also checking the cutaneous response of the fascia. I'm going to take an object, run it from the heel towards the ball of the foot. Took us a little bit. So negative for Babinski reflex. A Babinski reflex would be abnormal for a adult patient. Doing a little hand hygiene, if I can find where I set that at. Okay. And I think for a quick second. I think we hit everything. Did neural, we did 1 through 12, we did range of motion. All right, I believe this concludes our video. Thank you very much for watching. Range of